Okay, well, welcome. So I think this is a record crowd for our Winter Series on Aging first event, so thank you all for coming. I'm Ken Ottenbacher, Associate Director for the Musele Center on Aging, and it is my pleasure to welcome you to the 24th Annual Lefeber Winter Series on Aging. Dr. Elena Volpe is the Director of the Musele Center on Aging, and also extends her warm welcome to everyone. The Lefeber Winter Series is one of the most important aging-related activities at UTMB. It is a unique event that brings together faculty, clinicians, and members of the Galveston community to celebrate the dissemination, the application, and the generation of new knowledge in aging research and practice. The Winter Series on Aging is named in honor of Dr. Lefeber. Dr. Lefeber was a practicing physician in Galveston for many years, with a commitment to the care and health of older adults. He was not a faculty member at UTMB, but was a strong advocate and driving force in the establishment of the Division of Geriatrics in the Department of Internal Medicine. After his death, a donation from the family started the annual lecture series on aging named in his honor. I am pleased to welcome Dr. Bret Goodpaster to UTMB to present the first Lefeber Winter Series on Aging lecture for 2019. Dr. Goodpaster is currently Senior Investigator and Director of the Exercise Metabolism Core in the Translational Research Institute for Metabolism and Diabetes at the Florida Hospital in Orlando. Dr. Goodpaster obtained a bachelor's degree in biology from Purdue University, and after completing pre-doctoral fellowship in the Netherlands, received his PhD in human bioengineerics at Ball State University. Prior to his current position, Dr. Goodpaster was professor of medicine at the University of Pittsburgh Medical Center and chair of the Diabetes and Metabolism Research at the University of Pittsburgh. Dr. Goodpaster's primary research involves examining the pathophysiology of human obesity, insulin resistance, and diabetes. He has received numerous awards and honors for his work, including the Nathan Schock Award from the National Institute on Aging. This award is given to outstanding investigators in the U.S. in the field of aging research. Dr. Goodpaster has published over 200 peer-reviewed articles in the top journals in aging, medicine, and physiology. He serves on the editorial boards for Diabetes, the American Journal of Physiology, the Journals of Gerontology, and is currently associate editor for the journal Obesity. Dr. Goodpaster is a co-leader for one of the 7 clinical centers involved in the $170 million NIH-funded consortium called Molecular Transducers of Physical Activity, or MOTORPAC. MOTORPAC is a nationwide consortium that aims to construct a molecular map of the changes caused by exercise and help us better understand how exercise benefits human health. Dr. Goodpaster is widely known for his research on the athlete's paradox, which has shifted the paradigm in type 2 diabetes research to examine how and why fat accumulation in muscles causes insulin resistance in some subjects, but not others, and identify which are the good fats and which are the bad fats. He is going to share some of his research with us today in his lecture titled Mitochondrial Energetics and Insulin Resistance in Aging. Please join me in welcoming Dr. Goodpaster.
Thanks, Ken, very much for that introduction. Thanks for everybody for coming out this afternoon. It's a pleasure and a real honor to be here to give this lecture. Thanks for the Lefeber family for really generously contributing to our ability to have this lecture. It's good to connect with colleagues and friends here that I've known for a while, and many of you who I've got to know just recently. Thanks especially to Elena Volpe and Blake Rasmussen for the invitation to come here these last couple days, and I look forward to some more interactions the rest of the day today. So thanks very much. So we'll get started, and by the way, I know the room's fairly full, so if you showed up to the wrong lecture and want to scoot out, that's fine, no hard feelings. But if you want to stick around, hopefully you'll get something out of this. It's going to be a little bit eclectic because, as Ken said, I've done research in the area of obesity, diabetes, and aging. All of those diseases and conditions are really what we would consider complex diseases. You know, they're not a single gene mutation that causes diabetes or causes obesity. They're very complicated and complex diseases and conditions. And I think, you know, complex diseases and conditions require really more complex approaches in terms of investigation and research, both from a basic mechanistic standpoint as well as a clinical investigation perspective, as well as translating these findings into the community where we can hopefully realize, you know, the potential of what we find in the lab. So this is just a picture of my institute very briefly. Most of what I'll present, or at least the majority, will be from the work that I did over the 18 years when I was at the University of Pittsburgh Medical School. I've been in Orlando for the last 5 years. Some of the later data that I'll present in the talk will be from some of our recent data. But really the theme has been, among the themes has been to look at the power of exercise and in some cases weight loss, dietary interventions in treating these complex diseases, obesity, aging, and conditions of aging. So just to make sure we're on the same page, because I know we have a variety of backgrounds in the room, I want to just briefly give you the background on what insulin resistance is, particularly skeletal muscle insulin resistance and how it contributes to diabetes, type 2 diabetes. So essentially what insulin resistance is in muscle and adipose tissue, peripheral tissues, it is essentially that insulin cannot do its job effectively to cause glucose to be taken up by muscle, for example, and to be either stored or used as energy. Insulin is present in the circulation, but it can't really do what it's supposed to do. So some people call this insulin inaction, insulin resistance, but the point is insulin's there, it just can't really do what it's supposed to do. Now somehow the pancreas senses this insulin resistance and it tries to overcome it, and how it overcomes it, it produces more insulin into the circulation, and this works for a while, but in some people, and we don't know fully the reasons why this occurs, in some people the pancreas eventually can't keep up with this insulin resistance and it starts to fail, and this is the beta cell, the beta cells in the pancreas are what produces insulin. It eventually fails, and this is what results in hyperglycemia or frank type 2 diabetes. So that's really why insulin resistance is important, and many would argue, in many cases, the cause of type 2 diabetes. So I'm going to start off and ask some sort of questions that are, I would argue that some think are dogmatic in the field. Some think we know the answers to this. One of the questions I think is pertinent to this lecture series is aging associated with insulin resistance. We know that older people, there's a higher prevalence of diabetes as people get older, type 2 diabetes. Many people think that this is because as we get older, we become insulin resistant. And while that may be true, the question still is aging itself associated with insulin resistance? Is insulin resistance associated with obesity? Obesity is associated with type 2 diabetes, but not everybody with obesity gets diabetes, right? And again, this is one of the questions that people in the field would think, why are you putting this question up here? Because everybody knows the answer. Of course, obesity is associated with insulin resistance. Is aging associated with the reduced mitochondrial oxidative capacity? This is going to get a little bit of sciencey, right? Because mitochondria are the energy generating organelles in the cell. Aerobic metabolism, they oxidize glucose, lipid for energy. It's been associated with the aging process. In other words, as animals and people get older, there's an association with the reduced mitochondrial capacity, particularly in muscle and other tissues of the body. Another question that we in the diabetes and insulin resistance field have been trying to address for a couple decades now, or even longer, is mitochondrial capacity linked with insulin resistance and diabetes. I'm going to show some data for that as well. And I also want to put up some caveats here before we really get started and presenting some data. I do mostly human research. And we always get sort of criticized by some of our preclinical research colleagues that, human studies are great, but you really can't determine causality or mechanisms with human study. But I would argue that association may equal causality. If you see an association, it doesn't mean that it's cause and effect, but it probably means we need to get more data, whether it's preclinical mechanistic data or more human data, to really help address that causality. I would also argue that if you don't see an association, it means that there's no cause and effect, right? So that's sort of this go or no-go answer that drug companies are interested in. If you don't see an association, then why do more mechanistic studies? Because there's nothing there. So I think it is valuable to look at association. So here's one answer to one of the questions that I had right from the beginning. I'm just going to give you the punchline, at least in our hands, right? So again, we do human aging research, we do human obesity research, and I also am very interested in the effects of exercise on some of these diseases and conditions. So this is a paper we published back in 2009 to address in a very simple way, to answer that question, is aging associated with insulin resistance? And what we did in this study is we did hyperglycemic glucose clamps, and essentially this is a gold standard for measuring somebody's insulin sensitivity or insulin resistance. And Elena and others in this room have done these type of studies. But essentially, you bring them into the clinical research center, you infuse them with insulin and glucose, and you measure how responsive they are to insulin by how much glucose they take up. So the higher number here is a good thing, right? So we brought groups of subjects into our clinical research center who were, let's just call them younger versus older. And these were, men and women in their 20s and 30s versus women and men in their 60s and 70s. We had a group of athletes, normal weight, sedentary, and normal weight, obese, sedentary. We did these measurements, and the athletes had very high levels of insulin sensitivity. The normal weight a little bit lower, and the obese were the lowest in terms of their severity of insulin resistance or degree of insulin sensitivity. But you can clearly see, when you compare the younger versus older subjects in each of these groups, there's absolutely no difference in insulin sensitivity. So I would use this data to argue strongly that aging is not associated with insulin resistance, but rather it's driven clearly by chronic exercise training or obesity, but not aging. Okay, aging is associated with decreased physical activity and increased body fat, increased obesity. But again, these effects, I would argue, are secondary effects of obesity and inactivity and not a primary effect of aging. And I'll have some other data this afternoon, I think, that sort of support this. What I do think is important is perhaps not necessarily your obesity per se, but how much total body fat you have, but where that fat is located in the body. So these are two CAT scans, CT scans of two individuals that really highlight this example, I think, quite nicely. The person on the left has a lot of what we would call VAT, visceral abdominal adipose tissue accumulation, fat in and around the organs, versus the person on the right who has very little intra-abdominal or visceral abdominal fat, but has a lot more of their fat in the subcutaneous area, the fat that you can pinch under your skin. Okay? Despite having perhaps equal amounts of total fat. In our studies, when we look in relationship to this insulin resistance variable, again, high number is a good thing, a low number is a bad thing, we see that the relationship between visceral fat and insulin resistance is negative. So the more visceral abdominal fat you have, the more insulin resistant you are. So this is bad, right? This is better. And this is just men and women. You can see that there's really no gender difference. Both men and women essentially fall along the same line. Okay, so this type of correlation has been observed many times in the literature. But what has not been put in I think a good enough perspective is that how this contrasts starkly with the opposite relationship we see with subcutaneous abdominal fat, and this is in the thigh. And what we see, particularly in some of these older volunteers in these studies, is that if you have more fat in the thigh area, in the gluteus area and the thigh area, it's actually better, right? So this is a more healthy fat to have in terms of your insulin sensitivity. And we've done other studies to show that men and women who have more fat in the thighs and less in the abdomen are actually protected against metabolic syndrome and type 2 diabetes. So again, it's like real estate, location, 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 right? It's not how much total fat you have, it's where the fat is in the body that's really important. And I think it's highlighted in this same data set, and this is just a different way to show the data. Insulin sensitivity, 4 groups of subjects, high visceral fat, low subcutaneous thigh fat, all the way up to low visceral fat, high subcutaneous thigh fat. And you can see this incremental increase in insulin sensitivity. So I would translate this into less diabetes risk if you have low abdominal fat, high thigh fat, low diabetes risk. And again, we've got other data to support this. Other papers have come out to support this. And I think this has been a very consistent observation. Another observation that we've had along the way is that this fat in and around the muscle that we termed intermuscular adipose tissue is certainly present in obesity and in people as they age. It's, you know, the animal model counterpart that I would use as an example is if you go to the supermarket and you see the steak, you know, the fatty steak, the marbling, that's exactly what it is here. It's marbling of your muscle that you can visualize and even quantify or measure on these CAT scans or MRI scans. Some of our early work in obesity, back in 2000 when I was a postdoc, or just finishing my postdoc, we related these different fat variables that you saw in this image. Subcutaneous fat that I just showed you was perhaps a healthy fat versus this intermuscular fat in relation to insulin sensitivity. In this particular study, we see no association between the subcutaneous fat and insulin sensitivity, but there is a positive negative association with this muscle fat infiltration and insulin sensitivity. And so the take-home message here is that, again, it's not the fat around the muscle, the subcutaneous fat, that's detrimental or harmful metabolically, but rather it's the fat infiltration that's marbling in your muscle that's really, for some reasons, and we don't know why this is, that's a particularly dangerous kind of fat to have hanging around. So for Wagyu beef, it's good, but for us, it's not. We also have shown in exercise intervention studies that this type of fat is movable. You can change this kind of fat, so that's the good news. So when we have these obese people on a 16-week exercise program, they lose this intermuscular fat, and the degree to which they lose this intermuscular fat is fairly strongly associated with their degree of improvement in insulin sensitivity. And we don't see this with some of these other fat depots, right, like subcutaneous fat, for example. So we think this intermuscular fat, again, is a particularly interesting and important kind of fat that's uniquely related to insulin resistance, diabetes risk, metabolic syndrome, and you can change it with exercise. Now, going back to the aging story, so here's a parallel set of data that we had, because I think this intermuscular adipose tissue is interesting not only from a diabetes risk, insulin resistance perspective, but also from a muscle function perspective. We've done a lot of studies looking at body composition as people get older, how much muscle they're losing, how much fat they're gaining. And that's what this slide is. This data happens to be, and some of you in the room may know about the Health, Aging, and Body Composition study. In fact, Dr. Newman, who will be here, I think, next week, will talk to you probably more about this study. She and I worked together for 18 years when I was in Pittsburgh, and continue to work together, by the way. So Dr. Newman and I published this paper several years ago, in which in these group of almost 3,000 men and women followed over this 5-year period from this data. So this is change data. So the men and women, they're losing muscle, so these are based on CT data. So they're losing significant amounts of muscle over time. They're actually losing some, particularly in the women, they're losing some of this subcutaneous thigh fat, right? This fat around here. But look what happens to their intermuscular adipose tissue that's highlighted in purple here. Both the men and women gain this intermuscular adipose tissue. Even if we measure this in these men and women who are maintaining muscle, maintaining their weight, they're consistently increasing their intermuscular adipose tissue. And in our hands, in this study, this was a more consistent signature of aging than was the loss of muscle. So I think this is a very interesting, again, and unique fat depot from an aging perspective as well. So, like I showed you before, with exercise and muscle fat infiltration and insulin resistance, we also had the question about how does physical activity affect this muscle fat infiltration in older people from a functional perspective. And I'm not going to take you through all this data, but we were part of the LIFE physical activity randomized clinical trial on the effects of physical activity on mobility disability. These data were from the LIFE pilot study. So in Pittsburgh, we did a small pilot study leading to the larger LIFE clinical trial. And in this pilot study, we did some CT scans on some of these older people before and after a 12-month, so a 1-year physical activity trial. And you see in the control subjects, this is, sorry, I don't know what happened to my label here, but this is the non-exercise, the non-physical activity control over 1 year. And you can see that this is the delta, so this is not the amount, this is how much their intermuscular fat increased over just a 1-year period. It was about a 15 to 20% increase in just 1 year. And you can see that in the physical activity group, it didn't change at all, right? So in other words, the physical activity completely prevented this age-associated increase in intermuscular fat during this 1-year period. Now, if we were just doing a 1-year pre-post assessment of this intermuscular fat in just this group over 1 year, and we didn't have the control data, what would the conclusion be? The conclusion would have been that physical activity does absolutely nothing to intermuscular fat until you see the control data, right? And at the very end, I'll get on my soapbox and tell you a little bit about what I think how the aging field needs to evolve in terms of looking at these prevention effects. Because that's what I think this is. It's a prevention of this effect over 1 year. And just to put this in perspective, the subcutaneous adipose tissue was not affected at all by the physical activity intervention. So again, there's something about exercise, something about physical activity that is uniquely affecting this intermuscular fat. We don't fully understand why, so we're doing some studies now to try to better understand the biology of why this occurs. I want to direct your attention now from fat back to muscle because I think they're both important in aging and diabetes risk. This was a study that we published, again, from this health, aging, and body composition study back in the early 2000s to not only look and measure how muscle was changing in these older people over time, but also how the composition of the muscle, how the quality of the muscle might be changing. And this is one figure from one paper, but essentially it shows the muscle attenuation, which is essentially the muscle density, how dense the muscle is, which you can measure on CT or a CAT scan, related to how strong a person's muscle is when you have them sit in a chair and contract their leg muscle. So, and the punchline, the take-home message of this data for both men and women, if your muscles are less dense, they're weaker. Okay? And I'm not going to take you through all the data, but the message from a lot of the data that we put together was this muscle attenuation, this muscle density variable was strongly related to how much fat is contained in the muscle. So if you took the muscle out of the person, I'll show you some data on this, how fat the muscle is. Not the fat around the muscle like I showed you before, this intermuscular fat, but this is actually the fat in the muscle tissue. The more fat in the muscle, the weaker the muscle is. So this is the fat we're talking about now. So if you took a muscle biopsy, a muscle tissue, out of the thigh muscle, which we do routinely, and you look at the muscle cells, the muscle fibers, you can quantify this. And so on that previous slide, we're showing on a CT scan that the more fat in the muscle, the weaker the muscle. So we've done a lot of work with needle biopsies. This is just showing you what's potentially available in a typical muscle biopsy. There's a lot of these muscle tissue samples that are performed here by the UTMB group. We do a lot of these as well. We're going to be doing lots of these in the MotorPack study that was mentioned. And this just gives you a flavor of what you can measure in these biopsies. One of the things that we measure are the lipids in the muscle. So it's not just a blob of triglyceride in the muscle. And a lot of these studies, by the way, were led by Paul Cohen, who's working with me in Florida, to better understand not only how much lipid is in the muscle and how it's related to insulin resistance and diabetes risk, but the type of lipid. We know a lot more about these different types of lipids like ceramide and diacylglycerol and how they might be related to insulin resistance. And of course, to use the lipid for energy, you need mitochondria. So we think that the mitochondria for fatty acid oxidation are also implicated in the accumulation of these lipid droplets and some of these other potentially bad or good lipids. One of the data sets that we put together for a paper now almost 10 years ago in diabetes was in which we showed in muscle biopsies comparing insulin-sensitive subjects to insulin-resistant subjects. And these subjects were matched for obesity. They were matched for physical fitness, aerobic capacity. We simply wanted to look in these muscle tissue samples as to what defining features may put somebody at a higher diabetes risk. So insulin sensitive, low diabetes risk; insulin resistant, high diabetes risk. We showed that the accumulation of the ceramide in the muscle, which is a type of lipid, was strongly associated with insulin resistance. You can see that if you just look at the total amount of ceramide lipid in the muscle, it's about twofold higher in the muscle from insulin-resistant subjects compared to insulin-sensitive subjects. We also did a study to kind of follow this up, in which we wanted to look at the effects of both obesity and chronic physical activity in some of these lipids related to insulin resistance. So Francesca Amati, who was a PhD student with me in Pittsburgh, did these studies for her PhD thesis project. We did glucose clamps on normal weight, highly trained subjects, and these were all men and women in, again, their late 60s to late 70s. Normal weight sedentary subjects and obese sedentary subjects. Again, like before, we showed that the trained subjects have high levels of insulin sensitivity, and the obese subjects are very insulin resistant. We looked at some of these other lipids like ceramides. This confirmed our previous data. We showed that in the obese insulin resistant subjects, who again, these are not diabetic subjects, but rather at a higher risk for diabetes, have a high amount of this lipid ceramide in the muscle compared to the sedentary normal weight subjects or to the trained subjects. We also looked at diacylglycerol, which many people in the diabetes field have data in animal models, but also some in human studies showing that this diacylglycerol was one of the bad lipids. Well, to our surprise, because we thought the same thing, that this diacylglycerol was actually higher in subjects who were doing a lot of exercise. So in our hands, most of these diacylglycerols are probably a fuel source for muscle and probably a good lipid. But the caveat is, if you look at some of these diacylglycerols, it's the reverse, right? So some of these diacylglycerols are higher in obese muscle. And one of the take-homes here is that this story gets very complex and complicated. At first, we thought if we just look at ceramides and diacylglycerol, it's going to give us the answer. Well, we see that some are related, some are not. It depends on where in the cell it is, whether it's associated with disease risk or not. So that's one of the caveats here, right? And that's why we do research, to help figure these things out so we can go on to the next step and try to come up with answers. Another complication in doing human research is that all these muscles are not the same, okay? So these are MRIs taken of the lower leg, in which you can see different muscle groups. For example, this is tibialis anterior, this is gastrocnemius, soleus, and we came up with a method. At the time was fairly novel. Now it's a little bit more standard. We did a 3-point Dixon correction technique to essentially do fat selective imaging, and then with fat standards or lipid fat phantoms in the MRI scanner, we could quantify the amount of fat that was stored in the muscle. And one of the key results of this paper, I need to change my slide because it was published in like 2001 or 2002, so sorry about that. But the point here is that if you look at tibialis anterior, soleus, or gastrocnemius, the fat content varies quite a bit in these muscles. And you can see that it's only in the gastrocnemius do you see this difference between obese and normal weight subjects. In the tibialis anterior and the soleus, there's no difference in the fat content of the muscle. It's only in the gastrocnemius. And by the way, we see this in the vastus lateralis too. This is the muscle that we typically take the muscle biopsies from. So again, in our research, we're mostly biopsying the vastus lateralis, and this is how we interpret our data. But just, the caveat is if you biopsied another muscle, it may give you a different answer. Okay? So what about mitochondria? I alluded to the importance of mitochondria because mitochondria is important in providing energy for the cell. It oxidizes or burns fat for energy. So it's important from a metabolic standpoint. It's probably important from a muscle contraction and function standpoint. Those of you who have had basic biology classes probably remember the Huxley sliding filament model of muscle contraction, right? Where you get the actin and myosin cross bridges and ATP production. Okay, what do you notice about these electron micrographs? This is the overlap of the actin and myosin where the ATP is needed for energy, for muscle contraction. And look where the mitochondria are lined up, right? Exactly where you need the energy. They're positioned perfectly to provide ATP for muscle contraction. So these are two examples of electron micrographs, one from a master's athlete, 60 to 75 years old, and this is from somebody who's similar age except doesn't exercise and is insulin resistant. And you see this person who exercises a lot has a lot of mitochondria compared to this person. In fact, I'll tell you that, and we've done these comparisons, if I put this 70-year-old athlete next to a 25-year-old athlete, you cannot tell the difference. So there's something about exercise that preserves muscle well into old age. I'm not going to say that for all systems in the body because we know that the cardiovascular system declines with age and other organs and systems decline with age. But in our research, we see that people who are chronically physically active, particularly at a high level, are able to maintain mitochondria, maintain very good muscle health into old age. And this is simply a quantification of that. We can see that the mitochondria content in these older athletes is twofold higher than we see in some of these younger people, in the people who are same age but don't exercise. So here's where I talk a little bit about exercise, diabetes, and mitochondria. My mentor, who is an endocrinologist and diabetologist in Pittsburgh, David Kelly, published a really seminal paper back in the early 2000s in which they simply compared mitochondria content and mitochondria capacity in lean, obese, and type 2 diabetic subjects. And this paper clearly showed that there was a decrement in mitochondria capacity in patients with diabetes compared to obese and lean subjects. And so this really got people in the diabetes field thinking more critically about diabetes not only as a disease of impaired glucose metabolism, but also following the work of Sir Philip Randall and Dennis McGarry, and frankly the work by Bob Wolfe at UTMB, showing that fatty acid metabolism is probably just as important as glucose metabolism in diabetes. So part of my contribution or extension of this work was really to try to better understand whether mitochondria were implicated in age-associated insulin resistance. If there was an age-associated insulin resistance, many people, including the group by Jerry Schulman and Kit Wolf-Peterson at Yale, who published this paper back in the early 2000s in Science magazine, showing that older people were insulin resistant compared to younger people, and they had a lower ability from their mitochondria to produce energy. But I'll be somewhat critical because this cross-sectional comparison did not account for physical activity. It didn't really account for obesity in a strong way. But again, this was one of those papers where they just said, okay, these 8 older people, we'll just consider them older. It doesn't matter whether they're physically active or inactive, and we'll compare them to younger people. And their conclusion was that mitochondria capacity in these older people was associated with their insulin resistance. Well, we knew from our studies, and the group here have done many of these exercise studies in older people, and we, like others, have shown that exercise can indeed improve insulin sensitivity in these older people. They're not losing a lot of weight, but you can improve their insulin sensitivity. So again, this counters the argument that aging is primarily associated with insulin resistance. We also showed that their mitochondria content and capacity improves. And by the way, this study back in the mid-2000s was a study in which we simply had older men and women engage in a 12-week brisk walking program. And just by walking, they're increasing their mitochondria by 50%. I'm going to finish up in the last few minutes and talk to you about some unpublished data from a clinical trial we just finished up in Orlando called the MIRAGE study, Muscle Insulin Resistance and Aging Study. This was a randomized controlled trial comparing the effects of a diet-induced weight loss program. So they lost about, as you'll see, about 7 or 8% of their body weight. And then this group was compared to the same weight loss program except adding an exercise program. Okay, so they were randomized to 1 of 3 groups. Before the intervention, they had a VO2 max test, so cardiorespiratory fitness, their physical fitness test. We measured body composition with DEXA, CT, MRI. We did one of these glucose clamps, like I've shown you data for, to measure insulin sensitivity. We did 2 muscle biopsies before and 2 after, and then we had them come in and do some of the same measurements after their program. I'm not going to take you through all the details, but the glucose clamp was a 4-hour clamp for the aficionados in the room, a 40 milliunit per meter squared with D2 glucose tracer on board to look at both peripheral and hepatic insulin resistance. So this is the weight loss. The control group, probably a little better than normal because they're in a study, right? When you're in a study, your behaviors change a little different. This was not significant, but they lose a little bit of weight. The weight loss group lost, again, about 7% weight. The weight loss plus exercise group lost a little bit more weight. You can see that there's a stepwise increase in insulin sensitivity. The weight loss group improved, but the exercise plus weight loss group improved their insulin sensitivity even more. So there seems to be an added benefit of exercise on top of weight loss. We also, in the muscle biopsies, looked at mitochondria function. And here's where the weight loss and exercise interventions really diverge in terms of their effect. I'm not going to take you through all that data. You can kind of focus on, let's just say, the middle bars here. So this is the control group, pre-post. Mitochondria doesn't do anything, so we did a good job with the control group. They didn't change. Most people, when you tell them not to exercise, they're pretty compliant with those instructions. The weight loss group, they lost weight, but they didn't exercise. Again, pretty compliant with those instructions. Their mitochondria doesn't change. The exercise group, they did a good job on average, and you can see that they had a significant improvement in their mitochondria function. So it's really the exercise that you need to improve the mitochondria. And I won't take you through that. The improvement in mitochondria function in this randomized trial significantly associated with their improvement in insulin sensitivity. And we think this is really driven by the exercise effect. It doesn't mean they're necessarily causally related, right? It's association data. But nonetheless, when you have a change versus change, it's a little bit stronger. So we also had a subgroup of people with diabetes in our study. By the way, most of these people came in screening. They didn't know they had diabetes, but we kept them in the study anyway. And this is just a sub-analysis of this trial, because in the main trial we randomized 82 people. So it was a fairly large study for this type of study. So if you look at people with diabetes versus people without diabetes, you can see that both groups improve their mitochondria function with exercise. Right? There's some evidence out there that people with diabetes might not respond as well to exercise, but in our hands, when they do the same intervention, our conclusion is that people with diabetes respond quite well to exercise, at least with respect to their mitochondria content. And I'm just going to put up this data because this really corroborates a previous data set that we had in mostly middle-aged people that underwent bariatric surgery for weight loss. So the idea here was that if a little weight loss might be good, a lot of weight loss is probably better. So it's like a sledgehammer approach to the problem, right? We found that even with 30, 40 kilograms of weight loss, when these patients exercise after their bariatric surgery, they still see a better improvement in their insulin sensitivity. So there's still room to improve, even with bariatric surgery, when you exercise. And with mitochondria, very much like we saw in the recent study, these bariatric surgery patients just focus on these sort of bars over here. When they lose weight, nothing happens to mitochondria. When they exercise, they get an improvement. So again, the take-home message, weight loss doesn't help your mitochondria. It might improve your insulin sensitivity and certainly going to help with blood pressure, insulin sensitivity, your blood lipids. I'm not saying that weight loss is not doing anything, because it does a lot of positive things. But what I am saying is that exercise can do a little bit more in combination with the weight loss. So just some unpublished data to finish off here in the last couple minutes, because I know there's some interest in more of the mechanisms as to why insulin sensitivity might be improving with weight loss or exercise. So I told you we did muscle biopsies twice before the intervention and twice after. So one was a fasting biopsy, and one was when we were doing the glucose clamp with insulin stimulation. So we wanted to see what the insulin stimulated effect in the muscle was. So we simply measured, in this example, one of the proteins that's part of the insulin signaling pathway, AKT. And this is a classic signature of insulin signaling, and we showed that your AKT phosphorylation improves after the exercise and weight loss intervention. And you can see these are just individual subjects. This is just a subset of data, proof of principle, proof of concept, showing that we're activating this insulin signaling pathway in the muscle biopsies. But again, this is just one protein. Recently, and this is through our MotorPack collaborations, our MotorPack colleagues at the Pacific Northwest National Labs in the state of Washington, in which we're doing a global phosphoproteome analysis on these muscle biopsies. And you can see this is just one subject, biopsy, no insulin, and the same subject with insulin. And you can see that the number of phosphorylated proteins, and you can see it here, no insulin compared to insulin, the number of phosphorylated proteins increases dramatically in these muscle biopsies with insulin stimulation. So we're hopeful in this type of analysis to get novel information about proteins that we don't even know are affected by insulin and that are affected by exercise and weight loss to improve insulin sensitivity. So stay tuned. Maybe the next time I'll come, I'll have some novel proteins that'll be targets to help diabetes risk. The other caveat that a couple caveats that I want to finish up with we do exercise studies, and I was telling some people, Tatiana and Ray last night, and some others, that, we do efficacy research, and I want to understand what happens when people actually exercise. We know that when we put people in these programs, they're humans, you're dealing with human behavior. They don't always do exactly what you tell them to do. Imagine that, right? So these are data from our bariatric surgery patients, which, probably is a great example of, these are people who we were randomized to the exercise group, but you can see some people do a lot of exercise, some people do less, even though they're supposed to all do the same amount, right? You can see these two people after bariatric surgery were doing 750 minutes per week of exercise. So they found religion. But most don't. So insulin sensitivity, right? Exercise improves insulin sensitivity. This is the control group. If you do a little bit of exercise, you have some improvement. If you do more exercise, you get greater improvement. And if you do the most exercise, you get the most improvement. However, that's not the way with everything. This is VO2 max, cardiorespiratory fitness. The control group actually gets worse. So if you don't do any exercise, your fitness gets worse, even though you're losing a lot of weight. It's only in the high exercise group that you see this significant, robust improvement in cardiovascular fitness. So I think we have to be very careful in how we interpret some of the exercise data. And again, I think that's where the MotorPack study is going to be really valuable, because we're going to have some subjects who do less, some who do more, and we'll be able to see what some of these exercise effects are. But I'll just tell you that in these bariatric surgery patients, if you do a lot of exercise, it contributes to greater abdominal fat loss. So again, these are patients who are losing 30, 40, 50 kilos of weight. But if they're doing exercise over the long term, we think it's going to contribute to greater weight loss over time and greater weight loss maintenance over time. I think this is my last slide, and this is going to harken back to what I showed you earlier with some of our data. And, I'm probably preaching to the choir on this one, but, so if we do exercise studies in older people, and you don't see an effect, if you don't see an improvement, your conclusion might be that exercise is having no effect, right? If you just looked at this line. But if you look at this line compared to the normal aging process, or to what typically happens to people as they age, whether you look at muscle strength, insulin sensitivity, body fat, fitness, whatever, that declines over time, and maybe it's just a 1 or 2 year period or even longer. Unless you look at this effect in context, you're going to conclude that exercise is having no effect. But in reality, exercise could have a very powerful prevention effect. So it's really important to look at the control group in comparison to the exercise group. So with that, thank you for your attention. Acknowledge my collaborators, the MotorPack team, go MotorPack here. We're going to need a lot of help. It's going to be a big study. Thanks to the funding agencies, and again, thank you for your attention.
Well, I'd like to thank Dr. Goodpaster for just an excellent initial lecture in our 2019 Winter Series on aging. So we're scheduled to have some refreshments and wine, hopefully soon. and while we're waiting for that, we have some time for questions. Questions, comments?
Most of us do not have 100 minutes a day to do an exercise. What would you recommend to get us up into that high mitochondrial?
Well, so I'll highlight the one study that I showed on the slide, and I emphasize that that study was brisk walking. These men and women were exercising 30 to 45 minutes a day, 3 to 4 times per week. I think everybody, well, most people can do that. You don't need to do 800 minutes a week. 150 minutes per week, you can see substantial changes. Yeah.
How does that compare to what you just said to high-intensity interval training?
What's the question?
High intensity.
Is that similar or different than the long duration stuff?
It's very different.
But will it have the same effect
On what?
on getting the kind of results you're getting?
I don't know. You know, my educated guess, you know, being sort of from an exercise physiology background, certainly high interval training will have a very powerful effect on insulin sensitivity, mitochondria. Yeah. You know, people ask me what type of exercise should I do? And my answer is usually the type of exercise that you'll do.
Some data on the gastroc and the human tissue where IMAX is more important. Any thoughts on why it's specific to the gastroc muscle and not the other?
You know, that's a good question. So the question, why is fat content different in gastrocnemius in the lower leg versus soleus or tibialis? We don't really know. It's an interesting question. Gastrocnemius is a mixed muscle fiber type. It's got fast twitch, slow twitch. Soleus is mostly slow twitch. But soleus is a postural muscle, right? So it's chronically active. That probably has something to do with it. Gastrocnemius is only activated when you're active, walking, where soleus is active as I'm just standing here, gastroc not so much. So I think it's the muscle activation, the metabolic demands, but the short answer is we don't really know why that difference is. Yeah. Yeah, Craig.
I think it's a really interesting story. So I guess age is kind of just a number, but in terms of changing mitochondrial function with obesity or changes in age, is it quality of function?
Yeah, that's a great question too. So the question is, you know, as we get older, physically inactive, is it the quality of your mitochondria? Is it how much mitochondria? You know, I think it's mostly the amount of mitochondria, the quantity. The jury's still out on quality. I think there's something to be said for quality. And, you know, you and I have talked about this, and this is the power of some of the methods, you know, the techniques that we have to be able to measure mitochondria quality. I think it's mostly driven by quantity, but I think there's some qualitative changes that can occur too. Yep. Yeah.
What type of exercise was the most commonly seen or observed in this study, and how is that related with concern with all?
You mean in our studies, the most common type of exercise done? You know, most of what I showed in these studies, they're aerobic exercise studies. We have not done a lot of resistance exercise studies like the group here at UTMB's done. They've done a lot more in that area than we have. So when I talk about aerobic exercise, it's mostly walking, some stationary cycling. You know, in terms of risk for falls, you know, that's a great question about type of exercise. You know, some would argue that, you know, risk of falls is simply due to just weak muscles. Other would argue that it's a combination of that and, you know, postural stability and a lot of vision, a lot of other factors, right? So, you know, I don't know if there's good data on there on the type of exercise, the best type of exercise that's most strongly reduced or, you know, related to fall prevention. I would say that walking is probably pretty powerful in that, but you know, some people can't walk very well. So, and then you know, treadmill versus over ground walking, which is better? It's difficult to know.
UTMB Health, working together to work wonders.